Welcome to Premier Pain Talk, a podcast dedicated to expanding awareness about treatment options for people in pain. Each week, host Dr. Michael Danko from Premier Pain Treatment Institute in Cincinnati, Ohio, discusses cutting-edge treatments for pain management that are improving the quality of life for those suffering with chronic pain. Tune in now to learn more about how to relieve pain and restore your quality of life.
All right, welcome to another episode of Premier Pain Talk. I'm your host, Dr. Michael Danko, Premier Pain Treatment in Cincinnati, Ohio. So this is kind of an interesting episode for me, and a fun event happened this week. So our team, spearheaded by Daniel, has been working really hard on social media and putting videos and other kind of content like this podcast out for consumption. And we had our first viral moment as a I guess a social media enterprise, so to speak, and that was a video on TikTok. So, full disclosure, I don't even actually have a TikTok. Our practice has a TikTok, and I'm gonna have to get my own personal TikTok now so I can track all these trends and maybe make some independent videos or whatever. But we have a video on TikTok right now that posted this week and already has 150,000 new followers. We're getting message requests about appointments and how to become a patient with our practice, and that's kind of mind blowing to me. And so it's cool, it's humbling, and I've been spending all week trying to figure out how and why this happened to us in a good thing, in a good way. And then I was doing an injection for a patient yesterday, and she started talking about this video came up, and we started talking about why people gravitate towards some of these videos, what they could be beneficial for, what this podcast be beneficial for. And she made some interesting comments, saying things like, a lot of times a patient feels like their provider is unapproachable or kind of at a different level, or you can't really connect, or you're afraid or you're embarrassed to come to treatment, or a variety of reasons why there's kind of this invisible barrier between a patient and a provider. And I think that's where these platforms, I think, can really be powerful in helping you all that might potentially be a current or future patient at PPTI to start to get to know us a little bit and get a little bit of a feel for what we can do to try to help you. Because we're real people just like you. And we have good days, we have bad days, we have exciting things that happen, we have disappointing and sad things that happen, but we work really hard to try to provide good care for patients. And so when I look at our podcast in this episode here, I wanted to talk a little bit about what we do as a practice and some of the things that I think you might see when you come into the practice, and then shift into a little bit of the content of that video, because it was a video about a procedure that we do, and I think that some of the comments and questions that have come in from people who saw that video afterwards, I think could be a great topic for the rest of the episode today. So we are in Cincinnati, Ohio. We're primarily on the east side and the north side of the city. We have 4 offices, and we have an ambulatory surgery center. And I say that to kind of set the stage for that there's about 50 employees or so between those locations. There's 3 physicians, there's 8 advanced practice providers, and then a whole team of receptionists, medical assistants, lab personnel, operations managers and social media managers like Daniel. We have a CEO, we have a CFO, we have all the things. But we're real people, and we want to try to help people improve their quality of life and improve their pain control so that they can function and do the things they want to do. I have a dog. You might hear him bark at some point during this episode. His name's Milo. He comes into the office frequently, and you'll often see him when you're coming in for a visit or an injection. We have providers and staff members that are expecting children. We have tons of staff that have their own children already. I have 2 children. When we're doing procedures, I like to play music. I like to sing during these injections. So, a lot of patients tell me that I have a good voice, and half the time I think, yeah, it's probably because I'm poking you with a sharp needle right now, and just trying to, it's kind of one of those kill with kindness kind of scenarios. But I try to do things to make these procedures less stressful, less anxiety provoking, and try to help patients get through it. And some patients like my music, some people don't like my music. I play all kinds of music, so sometimes it's country music, sometimes it's rock music, sometimes it's folk music. If a patient really likes it, sometimes there's some rap music. The it kind of spans the gamut. I mean, I can't listen to the same thing every day, otherwise I'd feel like I'm in an elevator all day. But we have we want to get to know you. We want to see how we can help you. We don't want to feel like we're unapproachable. We want to make sure that your feelings are heard, that you feel like you're getting the best care you can. Sometimes this is medical care, and this is a directed care of the providers and towards the patients. So there are some times where our plans and what we think is best for you don't necessarily match with what is you think is best for you, and that's okay. That's part of life. But overall, I think in general we try our best to make everyone feel heard and try to address their concerns and try to get to know them. And chronic pain management, there's a couple parts of that. So chronic means a condition that is by definition more than 3 months in duration. And management, this isn't a one-time treatment and you're done in most cases. Sometimes that happens. Sometimes patient comes for a couple of visits, they get some procedures, they're completely pain-free and their pain never ever comes back. That's not really common with chronic conditions. So this is a management scenario. This is something where we're going to try to help you manage your pain long term and help you get back to living and doing the things that you want to do. And I think that's a great segue into this TikTok video that we had and how I want to kind of finish the rest of this episode. So the video that we had was about a implantable medical device called an intrathecal pump. It is another word for it is a pain pump or targeted drug delivery is another term. These pumps can be used for conditions outside of chronic pain, so it's really why it's more called an intrathecal pump, because it's talking about where the medication is being delivered, which is to the intrathecal space or the spinal canal. And in that video, one of our physician assistants, Lindsay, was refilling a pump for a patient, and I think the reason why the video is taken off is that patient was talking about how her life has changed. There was a procedure going on. I think there is a lot to be gained from watching educational content about procedures. But this lady was talking about how she is doing things with her grandkids, how she's being more active, how she's living again, how she, how her life was before, how it's changed. And I think that's like such powerful information, because that's why we do what we do. And a big reason we can do that is because we get to know you and we keep working, we keep trying to manage your situation. And that's where a pain pump is a great way to long-term manage people's chronic pain. So what that is, it's like I mentioned, it's a medical device that delivers medication on a continual basis to control the pain. There's a lot of misconceptions about it. A lot of healthcare providers don't really even understand them. It's a specialized treatment that pain management practices have a high level of knowledge about that not all specialties do. So the intrathecal pump, it's a continual management of your pain, and there's a lot of misconceptions about it. There's a lot that we don't understand as medical providers about it. This is a device that's primarily managed by interventional pain physicians, but there are some other specialties that do manage it and use it for other conditions outside of pain, like I was mentioning, like neurologists and physical medicine doctors may do intrathecal baclofen therapy for spasticity. There's also some niche uses for infusions into the liver and other things that are kind of a rare treatment that is getting researched and expanded upon currently. But as far as these devices go, the way they work is it delivers medication on a continual basis to try to manage and control your chronic pain. It's not intended to help with acute pain. So if you stub your toe, it's still going to hurt. If you have surgery, you're still going to need some management of your post-operative pain in the period after surgery. But that chronic condition, the one that's bothering you all the time, we're really trying to improve upon that. And so there is great level 1 data behind this therapy. The long-term data, there's 2 large level 1 studies that showed At 3 years, patients on average are reducing their pain to about a 3.5 to 4. So that's taking a starting baseline of at least a 7 out of 10 and reducing it to like a 3 to 4 out of 10. And so it's not going to take you to zero, but it's going to, ideally, and in most scenarios, and in my vast experience with doing this therapy, it's going to really control the overall pain level well, so that you can get back to doing things and living your life like the lady in our video. And that lady was there for her procedure. She wasn't. I mean, yes, she knew we were filming and that was happening, but that wasn't really as much of a cherry pick scenario as much as we were trying to get a video of a procedure that was happening in our clinic, and the focus was the procedure. But then I think the highlight of the video was really how much better that lady has become. And then when you're looking at this therapy, it's a low dose of medication. So there's a couple terms for this. We call it like low dose management or micro dosing. This is at a level that is going to help you function and do the things you want to do. It's not sedating and making you groggy and sleepy and like zonking you. This isn't like a hospice infusion. This is a low dose therapy. And most patients in our practice that have these devices, their average daily dose of morphine or hydromorphone is less than 1 milligram a day. So we're talking about even a hydrocodone tablet at 5 milligrams. That's, if you're taking that 2 or 3 times a day, that's like 10 to 15 milligrams a day of some. We're talking less than 1 milligram spread over 24 hours. So we're talking about really low dose therapy with this, and that's why it can help you to function and do things you want to do without the overly sedating effects. And in fact, most patients find when they transition from oral medication to a pump that their overall clarity and their ability to focus and the kind of mental fogging improves and gets a lot better. So that's kind of a high level overview of what the pump is. And then as we move into some of the questions and comments that were as part of that video, I want to talk about some of the highlights that I think would be great for the next few minutes here. So, what types of medications can we put into pumps? As I mentioned, there are chronic pain medications. There are also non-pain indications for the pump. When it comes to your chronic pain, which is mainly what we do at Premier Pain Treatment Institute, and cancer pain, so these pumps are great for intractable cancer pain as well. The two most common medications are morphine and hydromorphone, which is also called Dilaudid. Across the United States, those two are about equal in terms of usage. They're about 80% of the medications that are primarily driving the management of the pump. I think our practice is probably fairly similar. We probably, a lot of times we'll start with morphine when there's not a reason to choose something else, because morphine is FDA approved for the intrathecal pumps. It's been used for a long time. The safety profile has been well established. A third line medication that can be used as a primary drug in the pump is fentanyl. So fentanyl is a very scary word. I understand that as well as anybody. But fentanyl in medical uses can be safe. It can be very safe, and it's the most common opioid we use in outpatient surgery scenarios when we're doing anesthesia to try to control pain during surgeries, because it's a short acting opioid. So in a illicit scenario, we're talking about street drugs, and we're talking about all kinds of unregulated, uncontrolled stuff that happens out there in the world. It's very dangerous, very, very dangerous. But in a medical setting, and in like something like this intrathecal pump delivery, it's very safe. One of the most common drugs for outpatient anesthesia is propofol. So that's the medication that Michael Jackson's cardiologist was infusing in his mansion and killed him with. That's really dangerous. When an anesthesiologist or a nurse anesthetist is administering it in a controlled setting for your endoscopy, it's very safe. And I think that's the kind of, I say that to make an analogy but difference. There's huge difference between unregulated, uncontrolled, unsafe use of dangerous drugs and medical uses of drugs like that. And so these pain pumps, they deliver the medication with 99.9% accuracy. They're very accurate. They deliver it on target. I saw a study one time that if you looked at patients and what accuracy they take their medications. So if it says to take this medication at this dosage this many times a day, on average, patients take their medications with 24% accuracy. And so 1 in 4 times the patient's actually taking the medication accurately as prescribed. This pump is nearly 100% accurate with the dose it's delivering. And so it can be very safe in that regard. There is a non-opioid medication for the pump that is indicated for chronic pain and chronic nerve pain. It's called Ziconotide, or the brand name for it is Prialt. So that's another drug that can be used in the pump, and that's a great way to control chronic pain, especially those that have a strong neuropathic or nerve pain component to it. So things like complex regional pain syndrome, diabetic peripheral neuropathy, chronic radiculopathy, post-herpetic neuralgia, the conditions like that have a strong nerve component. Ziconotide is a great option. For those patients who have a mixed mechanical and neuropathic or nerve pain component, so they got the kind of mechanical axial pain along with the nerve pain. They're oftentimes will put a medicine called bupivacaine in with the primary opioid medication in the pump. So in that example where a patient starts out with intrathecal morphine for their pump, and it's being infused and it's controlling the pain, but they're still having some breakthrough nerve pain. Then sometimes we'll add a second drug called bupivacaine to the pump to carry along with it. And bupivacaine will help with the nerve component to the pain, and then that can be adjusted as well. And so when you're adjusting these pumps, if it's at the in between refill appointments, both drugs go up or both drugs go down. If it's at a time of refill, if you order different concentrations of the drug, you can independently change one dose of one compared to the other. So there's quite a bit of flexibility with how we adjust and manage these medications in the pump itself. There are other medications that you're going to come across that are used in the pump. As I mentioned a little bit earlier, there is a medicine called baclofen. Patients may be familiar with baclofen as a muscle relaxant they've taken. Well, that is as a muscle relaxant, it can be used in the pump. It can be a great way to manage chronic severe spasticity. So patients who have spasticity after a stroke, if they have cerebral palsy, if they have other conditions where they have spasticity and contractures and muscle spasms that are really severe, the intrathecal baclofen can be a great option. Rarely it will be added as a carrier medication along with opioid medications and bupivacaine and things like that, but that is pretty rare and not standard practice. More commonly, that intrathecal baclofen is a monotherapy or a single therapy driving a primary spasticity condition. As far as for patients who are out there in different locations and other practices, you may see other medicines in the pumps. I try to keep these pumps as simple as possible. I think that's very important because I think when you keep it as simple as possible, the quality control and the delivery of the therapy is a lot more reliable and consistent. But you will see multi-drug mixtures out there, and your providers, that you may be seeing may have particular reasons that they want to add other medications. And so like another medication that can be added in there is clonidine. So clonidine is primarily a blood pressure medication, but it does have some indications for nerve pain. One of the reasons that I don't often add baclofen and clonidine in addition in mixtures into pumps is because if the therapy is abruptly stopped for whatever reason, for example, if patient is hospitalized and for some reason nobody realizes they have a pump, or the pump runs out of medicine before they can be refilled, there can be some fairly significant side effects and risks when those medications wear off if we're not planning ahead. So luckily scenarios like that are very, very rare, and there are different alarms on the pumps that give you an idea that it's getting low or that it's empty. And so there are a lot of ways to prevent that. And when we look at these pumps every time patients come into the clinic, we look at their alarm dates and their interval dates, and it's a very regulated therapy in that regard. So I don't say that as a means to scare people, but I share that as a means of spreading information about why what is available, what you may see in a pump, or what may be offered to be put into your pump, and then also when it comes to the the long term maintenance of these pumps, why I try to take more of a minimalist approach in trying to keep the therapy as predictable as possible. So another question: how often are the pumps refilled? So the pumps are refilled on average about every 3 months. So this is a little bit variable from place to place, but at our practice we work with an intrathecal pharmacy that provides the medications. So these need to be sterile medications that are put into the pump. They can't have preservatives in them. So preservatives that are oftentimes used in medications to extend the expiration of the medication are neurotoxic, and so those preservatives can't be included. So when it comes to how often we refill it based on how long we expect the medication to be at its normal potency. So when they deliver medication, if it's morphine, the concentration is 5 milligrams per ml, we want it to be delivering at a concentration of 5 milligrams per ml. If it starts to fall out of solution and that concentration starts to decrease, the efficacy of the medication is going to decrease because you're not delivering the same dose you thought you were delivering. As I mentioned, the pharmacy we work with, they guarantee the medication is good for 90 days. It can be good for up to 6 months, but that's from when the stock solution is originally made in the pharmacy. And then you have factors like how long until the individual prescription was made from the stock solution, how long did it sit in the pharmacy before it was shipped to your clinic, how long was it sitting at the clinic before it was put into the patient, and so on. And so it could potentially be good for longer than 90 days, but it's only reliably good for 90 days. So, just like the gallon of milk you have in your fridge that has an expiration date stamped on it. Yeah, it might be totally fine to drink after the expiration date, but also it may not be. And so we have a 90-day kind of expiration date on the medications, and we use that to decide when we want to refill the pumps. And so every 3 months or about 4 times a year, the pump will get refilled with fresh medication. And then the question, what do these devices look like? So the best analogy I have for this is they look like a titanium hockey puck. So they're not small. They're about the size of a hockey puck, but they can't be any smaller because the medication in there is liquid. And so they can't condense it. I mean, it'd be cool someday if we can have some kind of gas vapor that can be somehow converted to liquid as it's going into your body, and then we can really make them quite a bit smaller. But I don't see. I think that's more of a for future generations and not our generation. So it's about the size of a hockey puck. It is circular like that. It does have a kind of triangular point on one part of it, and that's where there's something called the catheter access port. And that's how you can get access to the catheter. So sometimes we do something called a dye study, or we're changing medications and we need to clear any drug from the catheter itself and not just from the pump reservoir. There is the catheter access port. The refill port is right in the center of the pump. And so if you're coming in for your pump refill, there'll be access in the center of the pump to take the old drug out and put the new drug in. And then as far as comfort with that, I think that it is it's not small, but a lot of times for most patients we can place it in a location where it's going to be fairly comfortable and it's not going to be a big issue as far as that goes. So it is a risk that the patients may have pain from where their pump is located, but in my experience, and we manage about 500 patients actively at our practice. It is not a common issue that people are complaining about. So the last question is I think a direct result of the video we had reaching so many people. But this question is like, can a patient come from out of state to be a patient at our practice? And if you live close, if you live a drivable distance, so we are in Cincinnati, we are in the what area we call the tri-state. So we have Kentucky and Indiana that border us. It would be reasonable to potentially come in and be a patient of ours if you're in the greater Cincinnati area and like out of state in the coming from like a northern Kentucky or southeastern Indiana. But realistically, it's probably not feasible to long term come to us for pump management if you live further away than that. However, I would be more than happy to see someone for a consultation to help you figure out what a good treatment option is, whether something like an intrathecal pump is an option for you. The reality of chronic management is that there's often a time component or a frequency component to your treatment, and so it may be burdensome if you live far away to really come see us for a long-term basis. But when not everyone's created equally, not all providers are created equally. As I started out this podcast, I talked about how we're real people. If you bring in an electrician to do some work at your house, not every electrician does everything exactly the same way. Not every contractor does the job the same way. Not every soccer player playing for FC Cincinnati is at the same exact skill level. Different physicians, different providers, sometimes a fresh look, a second opinion can be really helpful. We offer a wide range of options, wide range of treatments. So you could come see us as an outpatient. We may have a minimally invasive surgery or an advanced procedure that isn't being offered where you're at that we could do, and you could see us on a limited basis until that is completed. We could potentially see if you're a good candidate for intrathecal pump. We can help you figure out if it makes sense to proceed with it. If there's someone that I know or that I trust or that could do a good job managing your pump back in your hometown. If it's a device like a spinal cord stimulator, once the implant is in place, a lot of the long-term management can be done remotely, and there's widespread representation across the U.S. for some of these more common medical devices. So while I obviously would love to see every single person who wants to come see me, I think there's some practical realities of coming in if you live far away. But sure, we're happy to see if you're a consult to see what kind of options you do have. See if a device like an intrathecal pump is an option for you, and then help if it so something that requires long-term treatment, help connect you with a really good provider in your area. And the benefit of getting older and being in this industry for a little longer is I've made a lot of friends, have a lot of connections, know people that may be able to help you locally where you live that you just don't really necessarily have the same access and resources to connect with independently. So with that, I'm going to wrap up today's episode of Premier Pain Talk. I really appreciate everyone chiming in. I don't think I don't know the magic recipe to making this another 150,000 view podcast or video or TikTok. Maybe Daniel can be working on that and for us. But I do appreciate everybody tuning in. Check out more episodes on any of your podcast feeds for Premier Pain Talk. You can go to our website at premierpaintreatment.com, and you can find us on other platforms like TikTok and YouTube and LinkedIn and Facebook and so on. So have a great weekend, everybody.